Good morning to the head of department, Dr. Bambang Widiantoro, cardiologist consultant, PhD. Good morning to the head of study program, Dr. Octavia Liliasari, cardiologist consultant. Good morning to all professors, consultants, seniors, and fellow residents. This morning, we are honored to host a guest lecture titled Transcatheter Aortic Valve Implantation in 2026, Where Are We Now? Before we start our agenda this morning, let us start with a prayer. Prayer begins. Prayer ends. This session will be moderated by Dr. Doni Firman, cardiologist consultant, PhD, and we are honored to have Dr. Abdurrahman Al-Moghairi, an interventional cardiologist from Prince Sultan Cardiac Center, Riyadh, Saudi Arabia, as our distinguished guest lecturer today. We also welcome our panelists, Dr. Amir Aziz Al-Katiri, cardiologist consultant, Dr. Arwin Saleh Mangkuanom, cardiologist consultant, and Dr. Nanda Iryuza, cardiologist consultant, who will be joining us from Zoom today. Now, without further ado, we would like to invite our moderator, Dr. Doni Firman, cardiologist consultant, PhD, to moderate our guest lecture session.
Dr. Indira. Assalamualaikum warahmatullahi wabarakatuh. Good morning. Sorry we are a little bit behind the schedule. So first of all, I would like, on behalf of Department Cardiology, Faculty of Medicine, Universitas Indonesia, I would like to welcoming Dr. Abdurrahman Al-Moghairi. Thank you for coming to our conference room. And then also we are really happy to be your mentee after you proctor us for 2 days in TAVR program, in program of King Saudi Relief Program. And I can also inform Dr. Moghairi that we also have a Zoom from outside all over Indonesia watching us this morning. So with me today, as the MC mentioned, that we have Dr. Amir Aziz Al-Katiri, Dr. Arwin Saleh beside me, will be the panelists, and we also have Dr. Nanda Iryuza, and I hope he already joined. Dr. Nanda right now in Stoke, UK, learning about TAVR. So he now in fellow in Stoke, in United Kingdom. So I think we can start our lecture by Dr. Abdurrahman Al-Moghairi with the title of the Transcatheter Aortic Valve Implantation in 2026. Where are we now? So time is yours, Dr. Al-Moghairi.
Is it working, this one? Did you hear me? Okay. I think the duplicate, okay, excellent. Yeah, I will share. Where is the share? You want me to open it first? Okay, share.
Sorry.
Will we go to the Zoom?
Maximize the slide first.
Which one?
It's opening Zoom application and share.
Yeah, it's already opened.
Sorry.
This one.
Yeah,
Okay.
yes, open.
Okay. Now where is the share? No.
Do you mind to sign in? Do you mind to sign in for your Zoom first?
Okay.
In order to join the share.
Okay. No, I think it's needed. It's
For the technical issue, I think
it's
to inform you in Harapan Kita, also in all over Indonesia, as part of the Indonesian networking. We know that the TAVR program already started since 2015 in Indonesia, but the penetration, we must admit, is really low due to the financial issue, because the price is really high. But I think we know that we have 280 million population right now. So in mathematically, we expect that 30,000 of them have aortic stenosis. And then, of course, due to the newest guideline mentioned, that like all over, patient with more than 60 or 70 years old, now the TAVR will be the primary of choice. So maybe the next 5 years, hopefully that Indonesia will increase
I have
the TAVR program, not only in Harapan Kita or Medisra. Hopefully, we can start all over Indonesia. Um,
yes,
in Harapan Kita itself,
Meditation, yes,
already
yes, yes.
11 years we started the program, so
This is the one.
we must admit that we only have still less than 40 patients, 40. So I think 36 or 37 is really low. So
Does it,
comparing to, let's say, Germany, they
Okay.
implant hundreds of thousands per year. United States, I think around 80,000, per year, and increasing. Japan right now also, and India also now increasing, but with their own TAVR product. China also, I think,
Zoom
will
meets.
be unstoppable because they have their own TAVR as well, and the population in there is really huge, 1.4 billion, I think. I don't know. Yeah, so this marketing is really low. So hopefully that, with increasing the number of penetration all over the world, the price will be come down.
From the Zoom account for the doctor team, and in order to share, in order to make the doctor team into much.
Here is the share.
So still we have some technical issue. So any addition, Dr. Amir, as the head of the cath lab right now?
Yeah, okay.
Okay, can you send the PowerPoint to us and then we will share the
Yes, thank you very much,
Yeah, it's okay,
Dr.
no
Doni.
okay? And then
Yeah, I think
you can share
it's
from
really
the
our
to the
Yes.
TV.
Yeah, it's okay.
it's really our homework is really to find
So we can share the share
um,
screen.
a correct
How
device,
you-
which is a suitable device, which is quite good for our population, as well as the affordability of the device itself. So I think this is the and the other thing, I think we as a national health center, I think we also have to persuade our BPGS, our universal health coverage, to really give some kind of facility for this, especially
another
for
computer
the
with
very
time
big
transfer
hospital in
in
Indonesia, to have a chance to
Yeah, the files.
do this kind of procedure, TAVR procedure, because I think this is very important, especially when our neighboring countries, all our neighboring countries are already on TAVR program and already increasing the numbers. And so I think this is our homework as a national health center, as well as a country, for this TAVR program.
I want to ask to Dr. Doni, since we have an issue with the price of the valve for the TAVI, is there any place that we could use a BAV, balloon valvuloplasty, first to bridge, to wait for the patient receive the valve, the TAVI procedure?
Yeah, I think we did some cases in our hospital. So
No,
the
it's-
BAC right
it's
now
in
is like you mentioned,
Ready?
Dr. Awad mentioned, is for
This is
bridging
your file.
for very symptomatic patient before we proceed to whatever is TAVR or surgery. But we also must pay attention for the valve characteristic. We don't want to have let's say AR, acute severe AR post BAV, because sometimes it's happened. Because if some, let's say, acute AR happens, so the heart will be standstill. So we have that kind of experience in our hospital. Standstill means the heart is stopped beating, just like that. Second, 1 second after we do a balloon, and then the heart will go stiff. We have one or two like that. So that's why the let's say the how to do the BAV also is not easy one. So we must be very, very careful to select which one, and then the diameter of the balloon will also must be in our mind, not too big, because we aim just for bridging, for whatever TAVR or AVR. So this is the class 1 in guideline.
Thank you, Dr. Doni. The bridging. Oh,
Now it's good.
Okay, I think
Okay.
we can see now the
Okay,
slide.
that's
Hopefully
good. That's excellent.
the Zoom audience also already see
Yeah, it's okay. Okay.
the member.
It's good.
So
Thank
okay,
you.
Dr. Amogari, please.
Okay, now we are ready, and thank you for hosting me today for this presentation. And we'll start without ado. As you introduced me from Prince Sultan Cardiac Center, as you see the logo, Prince Sultan is one of the it's a leading centers in the Saudi, and we are maybe the reference in the country and the region. And so the lecture today is will cover the evolution of the TAFI in the field of the intervention, because since the TAFR came, the shift is going to the minimal invasive and less complications. So, and then we'll take some highlights from the guidelines and the patient selection for this procedure, in addition to the some specific subsets of patients who can be selected for the TAFR, and then the procedure advances, then we'll end up with some future directions. The voice is clear, or? Okay, that's good. Okay, then since the 2025 and until now, the things moving very fast, and the expansion is huge in this field, and the indications expanded. The improvement of the device durability, the profile, makes these changes faster and faster compared to the time we started in 2008 in our center. So it's then now you have plenty and variety of devices to select among, and then the devices evaluated to the lower profile, better outcome, and looking for the long-term result. And where we are now, so the shift in the TAFE programs, no longer just for the inoperable, as we started in the beginning. Patients declined by surgery. There is no other option except TAFR in 2006. It is the primary modality for the treatment of most of patients in age 70 and more, and some of the guidelines, like the American guidelines, moved down to 60, and maybe lower with the improvement of the technology and the procedures. In parallel to this, the surgery improved also, moving towards the minimally invasive, the robotic, the endoscopic. So is the two modalities, surgical and transcatheter, improved in the same time. And the procedure success increased to approaching almost 100%, 98%. So the remaining is only 2%, with the risk is less than 1% risk of mortality in the procedure. And this is due to the experience of the operators, experience of the centers, improvement of the technology, improvement of the preparation, patient selections, clinical assessment, advancement of the parallel diagnostic, like the echocardiogram, and also the other imaging modality. It was dependent on the purely in the transthoracic, transesophageal in the past. We needed for the preparing the patient, then followed by the CT scan planning, replaced the aortogram and angiogram for the whole body, so reducing the amount of contrast slowly. And now on board, the MRI can be used for planning the procedure, and is taking more role in this part. And the mortality now is under, it started with mortality of maybe is 15%, then 10, then 5, and now it's approaching 1%. And in 2025 and 26 and forward, it's the transition from can we do it to how long will it last, and how do we manage the patients for the next 20-30 years. So it's the improvement is parallel in every part of the technology, in the clinical skills, in the procedure itself. So it's the evolution from the inoperable to the high risk to the low risk, and catching the patient early in the disease process, and cutting the part of the natural history of the disease instead of waiting until we see the end organ damage. And the clinical and this improvement, this advancement is supported by the clinical evidence, and also the evolution of the guidelines with the time, and the changing based on the growth of the clinical trials, from the randomized trials to the registry, and then now is moving towards the more advanced technology, more advanced skills, more advanced even in the surgical part. It's advancing, and now we can expand to the asymptomatic patients before the feel the disease. Once the disease started to have moderate, then the observation, recognition, and treating the disease early, and getting the patients now to the guidelines, and moving from out of the guidelines now is the class 2 to the patients without symptoms, and sometimes some patients with moderate disease. Once the end organ started to appear, like the LVH, the diastolic dysfunction, even from the echo parameters like the strain and strain pattern, so started to concentrate, and there are good number of or percentage of patients with the amyloidosis. So you treat the aortic stenosis and the amyloidosis in the same time. The treatment is available, and to catch the patient early. And in comparison with the just recent past, so is 21 to 26, also the shift is clearly appear, not only from the baseline we started in 2002, 2006, then 2010 and forward. So now is moving from the high risk, then to the intermediate risk in between, and now to the low risk and asymptomatic patients. And this one paralleled with the more depth assessment of the procedure itself, and also planning the future, moving from the primary disease to the associated problems like the coronary access, and also this makes the planning is very extensive and a huge in-depth assessment of the patients, and in the future it will be automated based on the AI digitalization, and became the standard of care, the TAFI, and this paralleled by the improvement in the patient preparation, and also the other supportive measures like the anesthesia. We used to use the patients, and all the patients ventilated at the time of the and general anesthesia at the time of the transapical, the time we started the TAFI in the early stages, and now then still general anesthesia for transfemoral, and now we do it under conscious sedation, similar to our daily cases in the cath lab, just local anesthesia and the sedation of the patient, and good pain relief. and the patient goes home earlier, shortening the hospital stay. In the technology side, in 2006, now is the movement towards to the shorter frame in the future. We may not see the long frame anymore. Some of them disappeared, like the Accurate Neo now is taken out of the market, and followed by the in the near future by the Evolute from the Medtronic and Navitor from the Abbott. So it's the since the Medtronic acquired the Dior AVR now, and it will come in the near future. Also the Abbott, they have their short frame balloon expandable valve is coming in the future, and now currently in hands we have two short frame devices, one from Edwards, one from Merrill, and both of them moved from the baseline now to the advanced, and the profile is lower. Now we are using it at 14 French, and in the future we see the as we noticed from the medical news on daily basis to the moving to the lower profile, less vascular access, because the vascular access is the most common complication: bleeding, hematomas, dissections, and physical occlusion due to the procedure or after the procedure. And if we move to the lower profile, we may treat more patients. We treat them in with the less vascular complications, and the on top of that is the duration or durability of the devices. Now with the new technologies from the decalcifications, valve preparation, valve engineering makes it more durable. In the in vitro and in vivo is reaching the 25 years estimated. Currently from the clinical trials is the 10 years now is achieved by the clinically, and we're looking forward. And because the we may see the future technology replacing even mechanical if the durability became in 30 years and more, like the polymers is coming now is in the surgical, but will move soon to the transcatheter, and will make the durability is it's not an issue because the advancing technology, and it has an impact. Major impact on the clinical, on the patient life, and survival and functional capacity and the quality of life. It will improve parallelly. For the current guidelines is moved down with the age. Instead of older age, now is getting less and less, and the clearly expanded for the commonly seen valve anatomy, which is a tricuspid valve. This is clear, and the expanded indications as we noticed, and the emphasis on improving and with the continuous education, continuous trials, and the strategy of planning for lifelong management and lifetime management, which is now is the era of treating the disease or preventing the disease before it happened, because the end organ is not an easy, the heart failure, the complications of the disease itself. So the drivers of this is clinical trials translated into the guidelines, and then the clinical trials, also the randomized clinical trials to support treating the asymptomatic and moderate aortic stenosis, and the improvement of the CT planning, and as I mentioned, the MRI, not write it here because it is not still standard of care. It's an alternative to the CT, but it's being used to overcome the issue of some concerns of the contrast-related issues and the kidney-related issues, or even the allergic patients, and also the on top of that is the heart team role in this part. So the heart team makes a strong role in the decision making. So in line with this, so the guidelines now is a class 1 indication to treat patients with tricuspid, and also the durability is shown and documented, and the expansion of the indications as we see. Then the lifetime management for the future patient treatment if they came back, how to treat them, and to plan it from the beginning, not to wait for the problem to happen. As we see the major changes in the heart team role, in addition to the age, the cut limit or cut point changed, and the also the lifetime increasing more and more concentration, and the lifetime includes the patient age, the durability, the access to the future access to the coronaries, and future removal of the valve if the surgical needed. So it's moving it from the replacing the whole aorta, now it's just only the explanting the valve, which is like a ring, small, so just collapse it and take it without major damage, compared to the extensive surgery, because the surgical is not an easy to redo surgery for a patient with a long frame and metal in the already industrialized in the system. And how to select the patients is based on the age, frailty, the comorbidities, at what stage in the disease process, and then the anatomy, suitability, and the majority of patients are suitable now, increasing the indications, increasing the inclusion of patients, and then to look for the lifetime management and improve the outcome with the optimization of the patient selections and procedure selection. What the evidence supports this procedure? It's the elderly patient with low risk. It started to have started with, then including the intermediate risk, so to make it the default from the standard of care to the default, and now to the treatment option and the selection of the patients for young, and the favorable hemodynamics with the device improvement and the technology improvement. Now the hemodynamics is better, and clearly the procedure patient mismatch is reduced by 50% compared to the surgery with the TAFI or TAFR. And the lower rate of events, the stroke rate is maybe less than surgery, the mortality is low, and also as hospital stays is low, and early discharges is with less medications, it's the role. And also the as we mentioned, is the clinic, the quality of life of the patients. It's very important. Remodeling of the ventricle in the future after treating the obstruction, and the midterm durability and reasonable 10 years durability is established. As long as the technology advances, the more patients treated, more patients included, and the improve the outcome with the time. So it's the different trials documented this with different also devices with the current and based on the future and the past experience with the all the devices, and even better with the coming devices and with the current technology also looking for the future. The asymptomatic severe aortic stenosis, early intervention is associated with reduced the irreversible damage of the ILFI if it has happened. So it's to prevent this damage before it happened. And now is a class 2 in the guidelines, and the careful patient selections and enroll them in the treatment. And this supported by the many trials, the recovery trial, Avatar trial, and only TAFAR trial, and EFORT trials. All the trials recruited the patients with low risk and intermediate with asymptomatic aortic stenosis, and they treated them early and proven the benefit of this technology. Moderate aortic stenosis with diastolic dysfunction or with the reduced ejection fraction. So it's yes, the mortality did not shown yet, but improved symptoms, improved quality of life, functional capacity improved, and they should be considered in the patients who came with this disease entity. And the trial which shown, this one is the unload trial, and it makes sense to relieve the obstruction, to unload the ventricle, and to give a chance for recovery of the LV and also the patient quality of life. Aortic regage, because until now the dedicated devices is limited to one device and not commercially yet expanded internationally, but there is a hope with the current devices. There are trials using the balloon expandable, self-expandable. Balloon expandable is more now because of the radial forces and better planning and taking the and supported by the NICE guidelines to selected patients and the emerging also technologies in the future. And TAFI in the bicuspid, because this is the most challenging and difficult. Yes, the prevalence of the bicuspid, as we know from the previous literature, is only 2%, but now is in the TAF era increased to 10 or more than 10% because of the more recognition, more reporting the cases, and do see it. And the challenge of the bicuspid in the TAFR, because of the elliptical shape, presence of raphe, which is prone to calcifications and more challenging, and fibrous tissue leads to some concern like the paravalvular leak, some complications, the rupture of the annulus of the expanded or oversized, because the diameter is different from the long diameter, reaching up to 30, 35, 40, and the shorter diameter is small. So, and to take the careful sizing, careful preparation and selection of the patients is also on board of the guidelines now. And the evidence is from the registry so far, and recent trials ongoing to prove this one, and now is in the guidelines in the class 2, and mainly for the type 1 bicuspid aortic valve. And probably the new devices improve the outcome because of the skirt improvement, and also the better sizing, better preparation makes this challenging anatomy now is feasible and treatable safely. When to consider TAFR in the bicuspid? In patients with the age group lying in the guidelines, type 1 is the most common. Luckily, it's mostly 80 or more than 80% of the cases, and that's why it's making them to be treated. And less raphe annular calcifications with better preparation, and also the favorable anatomy by the CT assessment. And also the challenges in the bicuspid and aortic regage, because it was contraindicated or excluded from the trials because of the failure rate in the past. Now it's supported by the evidence, and also this better selection of the patients, and in spite of that, still surgery is not eliminated. Still the class 1 indication and the preferable therapy for the bicuspid valve, especially presence of heavy calcium, coronary anatomy is not favorable, and aortopathy, which is an association with the bicuspid aortic valve, and as we know, is the associated with coarctation, associated with cerebral vascular abnormalities, and also the dilatation of the ascending aorta, and the risk of rupture and dissections is higher with bicuspid valve. Aortic regurg, because of the challenges in the anchoring the valve, the lack of calcium is an issue for the transcatheter therapy. But with the dedicated devices like the AnaValve or JanaValve or JenaValve technology, it may add more patients to the treatment. And in addition to that, there are maybe 3 or 4 technologies coming to compete with this and to improve the selections and increase number of patients treated for this. TAVI in low risk, because now is the movement is to manage the lifelong. So the movement is towards the shorter frame because lining below the coronary. So even if the patients after 10 years came back with a degeneration, you can still use the TAVR with the same confined size to the old device and treat the patient again and give them another 10 years from the current device. But with the future devices, it may last longer for this. And the first valve is rarely the last. So it's the treating the patient for the lifelong. It's now is the role, and considering the valve and valve and the TAF and TAF in the future and the skirts. That's why the supraannular, it may disappear with the time, because the supraannular, it reaches the sinotubular junction and blocks the coronary flow the future, and require the modification of the leaflet, either cut or eliminating the leaflet completely if it is long frame. But short frame lies below, and you find the percentage of cases required leaflet modification is less compared to them. And the explant of the valve, explanting the short frame, it's much easier and limited compared to the long frame, which required Bental procedure at the end because of the complete damage of the ascending aorta. The procedure itself improved even in terms of the long frame and supraannular, because you need to have the leaflet and the sinus aligned to help future modification of the leaflets if it's required. So the commensurate alignments, it's help the patients. We used it to help the coronaries in the acute phase. But it was helpful for even for the long term, for the degeneration in case of the future came. And in addition to that, which was an advantage, now is maybe an advantage anymore for the lifelong, because you want to avoid the conduction abnormalities and to use the cusp overlap to go high implantation. Now it's not the issue, because the conduction you have a treatment, but for the future access to the coronaries, it's more challenging. And in the technology wise, it's the improvement of the devices with time, improving the durability, improving the scale to reduce the paravalvular leak. Also for the small annuli and the patient mismatch or high gradient after the procedure, overcome by, yes, in the past it was the supraannular gives the better hemodynamics as of the smart trials or the others, but now is movement towards the improving the technology in the short frame itself, switching the valve at the frame itself, reducing the commissures inside the valve, so making the hemodynamics is better. Now we have seen it in a Merrill valve and also Edwards valve, the new technology making it better for the, and proven now is the expected trials to be presented soon will be the proof of improvement of the hemodynamics in the short frame device, because it's annular. That's why in the past the move towards the small annulus is supraannular. Now it's not an issue anymore, and improving with time. And low seated coronary heights, also another issue for both. But if we, as we see from the CT in the coming slides, is to match the coronary height with the sinus width. If the sinus width is reasonable, so the coronary height makes it down and down to even 5 or 6. We can accept it for the transcatheter, but we need a large sinus to accept this one. Otherwise, is taking the just optimal size and optimizing the result and trying to achieve the commissural alignment for the future access or modification of the leaflet. And also for the bicuspid, the assessment as well, and the new technology is also considering this one. The future coronary access is very important. And the heart team decision came on the top of the list of preparation and preparing the patient for this. Assessing the patient, planning it very well, and then the decision and the treat, then the follow-up for the future patients, whether the patient goes for the transcatheter or for surgery. The heart team decision is the top of the list. We take from the echo the initial diagnosis and the assessment of the LV assessment, starting from the valve assessment, the LV assessment, and also the ascending aorta assessment from the proximal part of the aorta, which is seen by the echo, even the descending seen by the transesophageal. And also the adding the to that is the 3D assessment. It's more accurate for the valve area calculation, and also the strain pattern and the longitudinal strain is very important to assess for the effect on the myocardium and detect the disease early before it comes more advanced and to reach the heart failure treatment. CT comes on board, and from the CT we take the many parameters, starting from the calcium to the area and perimeter measurements, and the diameters, and also to calculate for the sinuses, the coronary height, and the sinotubular junction, the leaflet calcifications, and the LVOT calcium and the LVOT calcium differentiated between presence of spikes or symmetrical and calcifications, the valve anatomy, bicuspid, tricuspid, presence or absence of the raphe, and the presence of the calcium in the raphe, and also the for the valve assessment, surgical valve, you take the VTC, the distance to the coronaries from the valve, and the size of the sinus and its relation, and also the if it is long frame, you take the sinotubular junction distance to the valve or to the frame. Because of the supraannular is close the sinotubular junction, then makes it difficult for the even with the modifications of the leaflets, if it is exceeding the sinotubular junction, makes the coronary access is challenging, and you may consider surgery if it is not suitable. Then is assessing for the access the femoral, or the alternative, if the femoral is not feasible, they extend the assessment. You see it in the report of the CT, assessing the subclavian axillaries and carotids, transcarotid approach if it is needed. What we need from the CT, as we mentioned in the table, you see the area is very important for the sizing the short frame or the balloon expandable, and taking with it is the derived diameter to calculate the oversizing, and then the coronary height, the sinus of Valsalva measurements, to calculate or to estimate the risk on the coronaries. If the coronary height is more than 12, this is the well established that the risk is low, with the Edwards reports from the partner trials, and now is coming down if the sinus of Valsalva is huge enough, and you need 3 millimeters from the valve size difference between the sinus and to the valve. So 3 millimeters is enough to perfuse the coronaries. That's why the height is coming down if the sinus is big. In addition to that, you take the estimated angle to deploy the valve at. So to take from the CT the estimated or the initial impression which view to go with, then to modify according to the patients and the anatomy, and to assess also for the angulation and the presence or absence of the horizontal aorta, because it's one of the challenging for the transcatheter. In addition to that is the vascular access, taking it from the femoral to the iliac and to the aorta, and to complete the assessment of the patient for the procedure. Then to go to the procedural advances and the devices lower profile systems, and makes it easier to use, and also the improved sealing to prevent the BPL, and positionable, repositionable. This is only in the self-expandable, but does not advance any, did not make any advantage for the in the future, because this device will disappear, and we have to prepare ourselves. And the because the self-expandable does not need skills, just position, reposition until you find the valve in position. While the yes is a very fast learning curve for the balloon expandable or short frame, but needs very careful skills and concentration on the parameters you need. But once you master the short frame, it's the procedure is what you need is only one way: accurately plan your procedure, accurately position your valve, and concentrate on the stability during the procedure. And the cornerstone of the stability is rapid basing. Confirm rapid basing, test it once or twice, 3 times, until you are sure that the patient does not have any missed beats. Then it will make the procedure very successful. Complications, still we do see them, but like the stroke, the other complications, but minimized to the possible, lower possible. Reducing the pre-dilatation, post-dilatation, it's associated with lower stroke, and the devices, protection devices, until now did not improve the outcome. Yes, in the device they find the debris, but did not translate in the clinical. The vascular bleeding, vascular complications and the bleeding, it's now is getting less with the lower profile devices. Improving the closure devices technology, reduced maybe 50% from the baseline. It was 20, 15, 10. Now it's almost approaching 5% of the complications. Mortality is low, and the pacemaker and the stroke still there, but with lower percentage, maybe it's 1.5% or so. And for up to 5% preference of the pacemaker requirement. Paravalvular leak reduced significantly by the planning and also the improvement of the technology itself with the presence of skirts, and the valve thrombosis is being reported with all the devices. It's more or less the same, and the medical treatment is improved, the technology is improving, maybe the valve engineering improving to reduce it in the future if it is related to the tissue itself or the stagnation of the blood once you crush the native leaflet. And we may see it in the near future, maybe in 1 or 2 years, we may see this AF range. So if it is generalized, it will eliminate the majority of the complications, which is the vascular complications. It will be eliminated by going with the lower profile. And also the durability also will improve. And also the will continue improving the quality of life and maybe the survival. Clearly treating the aortic stenosis prevent the sudden death, improve survival clearly by surgery or by transcatheter. Then the improvement in our preparation, our cath labs, our in the room. So now is moving towards the conscious sedation, local anesthesia, giving good painkiller locally. It makes it easy. And then the early discharge is the role now with the improvement of the procedural preparation and the patient preparation. Then the patient, they can go home early with the reduced hospital stay. Post-TAVR management is platelets. You need only one single platelets, antiplatelets, either aspirin or clopidogrel. Now is on board. Both of them similarly effective in this group of patients. If there is any compelling indication, atrial fibrillation or other indications for the anticoagulation, it's the NOAC is the way to go, like apixaban or rivaroxaban or redoxaban, according to the availability. And once you have the patients with the anticoagulation, then you don't need the antiplatelets. Is enough for the anticoagulation. And shorter monitoring of the patients if they need monitoring, and the early assessing seeing the patient in the clinic, then the follow up regularly, and the early mobilization of this. And the future directions for young patients, lifetime management, looking for the future, either the coronary access or the next procedure, next surgery. So those are taken into consideration, and the durability, it's coming with the data emerging for the improved engineering, and in the lifetime we keep the coronaries on the top of the list. Redo strategies, either surgery or non-surgery, and valve or valve or the explanting. The explantation, it's yes, with the short frame, as we mentioned, it's easier, and the CT comes for planning, even the future procedure. The CT planning and the image assessment is very important. And the risk on the conduction system, even with the second procedure, it's not eliminated. Still you have the risk unless the patient has already the pacemaker, so it's the conduction is the procedure innovations is the leaflet modifications for the future, either the device based or the perforating the leaflet and cutting it either with electrosurgery or balloon tearing it. Those are the techniques used. And the TAF and TAF strategy, is it short frame and short frame, or short and long, or long and short? As of now, the devices are available to improve the vascular access in the future. And post-TAFI medical management. So we do see some emerging trials to support the SGLT2 on board to prevent the post-TAFI complications, because now the SGLT, it's part of the treatment of the heart failure, now is being studied for the its role in the severe aortic stenosis post-TAFI, and simplify the thrombotic strategies, either the anticoagulation if it is indicated, or platelets, antiplatelets is, can be used, and the early mobilization, rehabilitation, cardiac rehabilitation protocols are very important, and focus on the heart failure optimization in patients with the heart failure, and the device technology, the profile, the durability, and also the if there is any way with the technology to reduce the pacemaker rate, or and also the CT imaging in general, either the baseline echo, baseline CT planning, MRI, and to plan the procedure. And the workflow and the program optimizations is the role is to go for the minimal invasive, and the same day or next day discharge is in our lab is next day discharge. We get the patients in the today the procedure done. The patient came in the afternoon, and in the morning the procedure done. The next morning patient go home. Some patients we discharge them home immediately from the cath lab after 6 hours, but we did not generalize it yet, just only selected patients. And the streamline cath lab and hybrid ORs workflow, it's also its optimization is very important. Improvement of the cost effective with the large amount of devices comes, and improve the reducing the cost, and also the also in the cost is not only for the device itself, but also for the hospital stay, for the future outcome, and throughout the procedure and the disease management. The operational improvements started from the planning and the cath lab improvement, also in the post-procedure monitoring and improvement and monitoring, and then the discharge and follow-up in the future following the patients. And the limitations until now is the some of the complications, like the conduction disturbances and the stroke still there, concern. Luckily the percentage is low, and the other also the concern is the leaflet thrombosis. It may improve with the technology in the future, but currently the guidelines support for patients with no indication for anticoagulation. It's the platelets. There are some observations and also recommendations, especially in the beginning, similar to the patients who had surgery, valve after surgery, replacement surgically. They recommend anticoagulation for 3 months. The surgeon, they continued. Then they don't need it anymore. But in TAFR early we started this one, but we did not find the differences, and the guidelines goes with the antiplatelets is enough. Single antiplatelets is enough for the routine cases, unless there is an indication, as we mentioned. The cost, we mentioned it already, and this one is very important. And key take away messages is the low risk elderly patients is standard of care. Patients with bicuspid aortic valve is careful selection of the patients, and selecting the majority of patients, because since the type 1 is the most common, probably is the treatment of choice for this patient. Valve and valve is an excellent option with proper preparation and planning. The lifetime management, it's for the future, it's the role of the practice. And the future directions, it will be is a technology based. The AI-driven planning, sizing, and everything will be automated, and also in modeling, the simulation by computer before they come to the patient. It's now is ongoing and growing. So before you go to the patient, you know the imagination of the procedure before you come to the patient. Then you come, and also in the cath lab with the improved also the technology, they can give you the the heart navigation, the simulation live. You push your valve and put it in this frame, even live in the patient, and then start your pacing and deploy your valve, and the expansion to the low risk patients and moderate AS, treating them before the progress of the disease, and continued reduction of the complications, as we mentioned, from the low profile devices down to 8 range in the future of this 1K. And as we see, as younger patients, earlier disease treatment, imaging improvement, bicuspid aortic valve and the complex anatomy, redo interventions, cerebral protections, if there is any device coming to prove this, or will be probably it's definitely taken out. But there is a certain patients, they need the protection. Valve and valve, maybe one of them, degenerated valve associated with a high rate of debris. And thank you very much.
Okay. Thank you, Dr. Magari, this very comprehensive talk. So we have our panelists right now. So I may invite Dr. Arwin maybe for the first comment or any question.
Thank you, Dr. Doni. Thank you for your lecture, Dr. Al-Mogeri. It is very comprehensive. Just wondering about the durability of this particular TAVI produced by Merrill. In your clinical practice, how long it would be last? Is it about 10 years or 15 years? And how about if the valve doesn't work properly anymore? Is the TAVI in TAVI using the same valve is feasible, or we have to use another type of valve? Thank you.
Thank you for the question. It is very interesting because now the durability, the proven by the trials, it's documented is 10 years. Beyond 10 years now is beyond 15 years, because now is 15 years is from the observations is there, but beyond 15 years is still too early to judge on this in the current devices. But in the future, because some devices they claim is maybe 6 billion cycle in the lab. Once they documented 6 billion or more cycles, that means the durability is 25 years. Because the valve started 2002 for the inoperable patients. We did not expect them to stay alive until now. Majority of them, they died because of the natural history and their age at that time. With the recent on board involvement of the young patients, we expected longer life, and we do more, see more redo cases with the devices currently available. Yes, they improved. Then the term of the selection of the device, then the CT comes, and you have to evaluate the patients properly. If the patient is not suitable, completely excluded, then the surgery is with its complications, with its challenges, is the way to go. Those who are suitable for the valve and valve, then to select the valve and valve for the current situation after a proper evaluation. And for short frame is easy to decide, because it is below the coronaries, then whether you select the long frame with the some excuses, explanations to improve the hemodynamics. So, and then you say this is the valve will stay 10 years, and then the third valve will come, will be the challenging. You have now to modify the leaflet, because now you go with the supraannular. But if you select the same frame, if it is short frame and you select the same frame, especially if it is large size, still you can 29, 26, still you can use the same short frame into the short frame, and you will have the good result. But for the small, like 20 or 23, you may say, I wanted to have a better hemodynamics to help the patient listening the mismatch. If the reason is a mismatch and high gradient and a small device for the patient, then probably is the best option is the surgery to avoid this one, because the surgery may enlarge the annulus and the root, enlarge the root and expand it and implant some device, or to select a mechanical device which is durable, and hemodynamics is better with the mechanical.
Thank you very much.
We have next Dr. Amir Aziz. Any comment?
Yes, thank you, Dr. Mugare. It was a very excellent and very true explanation regarding the update of TAVI, especially when you talk about the lifetime management. I think we have actually for the TAVI in TAVI or TAVR and TAVR is not going to be a problem in Indonesia in the next few years, because a very low number of TAVI. But the problem is we have many patients with the bioprosthetic valve in the aorta, especially patient with rheumatic heart disease, and it fails. I think the bioprosthetic fails. Do you think there is a place for TAVI in this kind of patients? Because most of the time these patients had surgery, had a bioprosthetic valve in the very young age. So it is most probable that these kind of patients will have, some kind of bioprosthetic dysfunction. And most of the time it is aortic becoming stenotic. Do you think this is going to be, there is a place for this kind of patient? And the second thing, you haven't mentioned about the comorbidity of aortic stenosis and coronary artery disease. What do you think is the approach? What is the threshold to send the patient to surgery, or you probably will do TAVR plus PCI? What is actually your threshold? Because of course in our hospital, if you have a significant CAD and significant aortic stenosis, definitely we will send directly to surgery. But do you think there is a place for the PCI plus TAVR in this kind of patient? Thank you.
Okay, thank you. The first question for valve and bioprosthetic failed, structurally failed bioprosthetic, it depends on the surgical valve, the size, type, and also the relation to the coronaries, the height of the coronaries, width of the sinus, sinus-tubular junction. So to take all the measurements together, then to decide about the valve and valve. If the size is too small, then the device, it may end up with the high gradient, and then it will push you towards surgery. But if the size of the original device is big enough to accommodate good size valve, this is then assessed for the coronary risk. And if the coronary risk is extremely high, then the surgery is the way to go, to at least to protect this one. And they may consider the mechanical valve if the patient is still early or young. And there is if the coronary risk is intermediate, or can be eliminated by modifying the leaflet to protect the coronaries, then the valve TAVI in prosthetic valve is reasonable, and it will sort the problem. And the type of the original procedure of the valve or by prosthesis is very important. Is it expandable or fracturable? If it is non-expandable, non-fracturable, so then you are limited, and you may also, it may push you to surgery back again. Those are related to the valve and valve. And in terms of the coexistent coronaries plus the severe aortic stenosis, then take the patient age. What's the patient age? And take it in. And how significant is the coronaries? Is it distal diffuse disease or left main and proximal LAD or ostial or proximal RCA major fizzles? If it is left main, then see how is the surgical risk. Is the surgical risk is low to send the patient for surgery to fix everything, or the patient is it's not surgical, then you treat the, because the guidelines now is make it open, and there is no benefit of treating the coronaries in advance. Treat the TAVI, priorities for the aortic stenosis to improve the outcome, to improve the output, and to improve organ perfusion, and to minimize the risk of hypotension and complications from the hypotension during the coronary intervention sometimes. Then if the hypotension happened in presence of the critical aortic stenosis, then the patient recovery with resuscitation is low. So that's why they give the priority for the severe aortic stenosis before the even left main. Treat the severe aortic stenosis, then it will give you chance to prepare the patient for the left main PCI. You can treat them both in the same time in the same procedure, and sometimes they use the mechanical support device like the Impella or ECMO or whatever the device is available in the hospital, and they treat the coronaries, because once you implanted the valve, the valve is it's not good to use the Impella anymore. So try to find another device with a lower profile, because it may damage the valve or may dislodge it or something. If the coronary disease is a mid or distal, then if you leave it even, it's not, unless it's subtotal or very critical, then you treat it either in the same time with some events from the load of contrast will be higher, and also the procedure will be lengthy on the patient. So then you can stage it in the future, the coronaries. Mainly, which carries the high risk, is the left main or ostial RCA. So those are the major players, or proximal LAD, and the major players in the decision on spot to treat them. Otherwise, you don't need to put weight on the coronaries in comparison with the aortic stenosis. Aortic stenosis is more important for the patients.
Okay, so may I invite Dr. Nanda? Dr. Nanda, are you here? Already joined the Zoom?
Yes,
Nanda?
Dr. Doni.
Okay. Yes, Dr. Nanda, how good early
Sorry.
morning. So it's 2 a.m. in the Stoke, I think. Okay, Nanda, you have some comment?
Yeah. Okay, thank you very much, Dr. Doni, and thank you, Dr. Al-Mugairi, for your lecture. So maybe I think I will agree with you that the CT imaging really plays an important role for the TAVI planning, not only for the accurate transcatheter valve sizing, but also to assess the vascular access and then the anticipation of potential procedural complications. And I think all the TAVI implanters should be able to be independently interpret the CT imaging to anticipate challenges and any complications that may occur. So my question is, I think because, as you said, that nowadays the age of the patients now become younger and younger, and they may require future coronary interventions like PCI in this case. How should the valve choice and design be considered to optimize the post-TAVI coronary access, and which valve design features should be taken into account to preserve the access of the coronary ostium for the next PCI? after a TAVI? Thank you, Dr. Al-Mugairi.
Welcome. Thank you for the question. It's very important. Yes, even in the surgery now, for severe aortic stenosis, they make it, probably it will come in the guidelines, maybe class 1, to do the CT routinely for the preparation of the aortic stenosis therapy, because they will plan how much root enlargement to do. What is the ascending aorta? What presence or absence of the calcium, where to put their clamp. So it's very important, the CT from the surgical point of view. From our side, it's not our preference, but the world now is moving towards the changing the technology towards the shorter frame, because now with the era of the lifetime management, the durability, the treating the patient for the whole life. So it's the movement is towards the short frame devices. And the short frame as of now is balloon expandable. We may see in the future the devices moving to the shorter frame with the self-expandable, and we may see also the motorized, completely automated. Just press the button and deploy your device in the future. Being tried with the Centera in the past, but because of the battery, they stopped it. They did not continue. I don't know whether they will resume it again or no. But probably is ongoing technologies from the China, and also I heard from also the some the manufacturers in India also, they are working on this to make it motorized and to make it the same length of the balloon expandable currently will be the self-expandable and motorized, because the self-expandable to control it manually, probably it's maybe challenging. Yes, we see the like a capsule in the deployment, like the Accurate Neo, but the Accurate Neo is only one way. But the Gina valve or Yana valve, the one designed for the aortic regurg, with the anchor from upper side, they open the anchor from the lower capsule, then push the valve and resistance against the sinuses to make stability of the valve until it released completely. This is one of the ways to make it. And also there is a new device designed for the aortic regurg from the Edwards. They call it Sojourn. It's still not FDA, not CE market, but it's very short. It's as short as the Sapien, and also it's designed for the treatment of the aortic regurg, because the self-expandable, it's not good for the calcium. We see it from the Medtronic, we see it from Abbott, because they need to pre-dilate, post-dilate to prepare the, and also in the bicuspid is challenging with the infolding of the valve. That's why the balloon expandable now, because of the radial force is strong, it holds its position, and maybe for the near future, it is the device of the future for coming 10 years.
Any more questions? Nanda?
That's all, Dr. Doni. Thank you very much.
Okay, thank you. So maybe I see some tick box in the Q&A. Is there somebody asking in the box? In Zoom, look like some, I don't know, one or two questions. Is there any? No? Chat? Oh no. I think just some announcement. So is there any? We will take one question from the audience. Maybe is there any question from maybe residents or fellow? Yes. Yeah. You mention your name and.
Thank you for the opportunity. My name is Putu Reza. I would like to ask about the post-procedure of TAVI. If the patient had maybe like total of a block from the procedure, based on the guideline, they say that we can evaluate until 48 hours if it transient, or maybe we can longer the evaluation between 2 until 7 days. to do the pacemaker. But based on your experience of the TAVI procedure, is there any cutoff that we can decide that we can do earlier for pacemaker, or maybe is there any management or medication that instead of we know that the mechanism of the AV block is because of the compression of the his bundle system, but is there any medication that we can use, maybe like steroid, instead of maybe inflammation is minimal in patient from the V procedure? Thank you.
Thank you for the question. It's very important. It's in two parts. One is the patients with high risk already, heavy calcium, presence of bundle, either right bundle or left bundle. Right bundle is more, presence of atrial fibrillation. It's those are risk factors for the AV conduction problem and the requirement of the. If the patient has a baseline abnormality, then don't wait for no more 48 hours or maybe maximum 12 hours or 24 hours, and because once the patient developed complete heart block in the cath lab, most likely he will require pacemaker, and we implant it immediately on the spot on table. So we call if the patient is an older patient, has only the single lead, then the micro wire leadless pacemaker, they come and they insert it from our same axis, venous axis. So they just upgrade the size and drop the micro or leadless pacemaker. If the patient just only he had no conduction abnormalities and developed bundle branch, left bundle branch is part of the procedure. If he developed right bundle branch block, then observe it. And if he has baseline left bundle and now became right bundle, or baseline right bundle and developed left bundle, this is a predictor of the complete heart block, and go ahead and fix it and put the pacemaker. Pacemaker is a treatment and improving the survival or saving the patient life, because some patients, they come with a conduction problem and you implant the pacemaker and you treat them. Yes, is in the studies considered one of the comorbidities and the complications, but I think it's not a complication. This is a natural, because the conduction system and affected now and luckily you have a treatment and a curable treatment. So don't leave the patient with the high grade AV block for the observation too long, because the more you keep the temporary wire, the more complications, infections, especially the venous, it may prone the patient to less mobility, because sometimes goes from the femoral. So it's the decide early on the patient. Don't delay it until 48 hours, or because the problem comes with the patients who had no conduction abnormalities in the cath lab, and no issues in the cath lab, and you send them home. Then they may develop conduction abnormalities after 7 days, 14 days. We do see some small number of patients, but once they come. And that's why the patient monitoring, continuing to follow them and to instruct them if you have any issues, any symptoms, any signs of conduction abnormalities, come back to the hospital to have this. And the patient who came to us, we treat them with a pacemaker. We don't know it. Yes, the procedure, it may be associated with some edema around the valve, or some, especially with the pre-dilatation, post-dilatation, and you may look for the recovery with the observation. But some patients, you deploy it from the beginning without pre-dilatation, without anything, and the patient went into complete heart block, then probably the likelihood of requiring pacemaker is very high, and that's why you need to decide early.
Okay, are you satisfied, Dr. Reza?
Thank you, Doctor.
Okay, great. So I think we already have all this discussion since our patient already ready in the cath lab. So I would like to say thank you again for Dr. Al-Mugairi for the lecture and discussions. And also I must say thank you also to the all audiences, especially on the Zoom from outside Harapan Kita, and also the resident and fellows. So I'll conclude this session. Thank you very much. Good morning. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much. Salam.
Once again, thank you to Dr. Al-Mugairi and to moderator and all panelists. To end this session, we would like to invite Dr. Amir to the front to present a token of appreciation to Dr. Al-Mugairi, followed by a photo session joined by Dr. Doni and Dr. Arvin as well.
Thank you very much.